patients love to be able to be put into the driver's seat with these types of decisions prior to having the treatment started.
So my guess is when that patient leaves and they show their family and friends, that's the moment where treatment is like locked in for them. They like fall
Yeah,
in love, they're
yeah,
committed. Now they're coming back saying, when do we get started?
that's typically what happens. I have to say that in my experience in recent years, once we get to this point, the next visit, we are scheduling our prep visit. I was an analog general dentist 10 years ago. Within a short period of time, when I invested in learning some of these CAD designs, I like to think of it in the fact that I know maybe 4 or 5 pathways within the lab software. The first pathway is to learn how to do a digital wax up. And so that's basically one pathway that I know. I'm going to repeat the same steps each time. And this, honestly, at this point, I can do these in between patients. They don't take me a lot of time. If I'm going to do, an 8-unit wax up like this case was, I can do that in under an hour. And that has just made me so much more confident in the presentation of the case, the execution of the case. And I think that's really what doctors want. I think that's what they want out of digital. I think digital promises doctors a lot of things. It promises to have better case acceptance, and you're going to have more predictable results, and you're going to, be able to do cases that you couldn't do before, or make more money than you did before. And how does that actually happen? It's actually this right here. It's actually knowing how to apply all these steps and put them together.
Hello, Rob Lejeune and Dr. Naren. Rajan here. We're going to talk about anterior aesthetics. Dr. Naren, talk to us about just doctor confidence and patient confidence in treatment, especially with anterior aesthetics. It's a little bit more of an emotional decision to make a purchase and say yes to treatment. Likely it's going to be a cash patient. And how your confidence in treatment outcome and the patient's confidence is so important to the patient saying yes, and then how you use these digital tools to give you the confidence that you love the smile, the patient loves the smile, and everyone's going to be happy with the outcome.
Yeah, that's a great question. I think when I started getting involved with digital dentistry, it was really to build confidence in my cases. Yeah, after buying an intraoral scanner and realizing that we could eliminate a lot of the impression material, the next natural progression was, how do I use some of these tools in my practice to get more confident case presentation, to be able to execute cases that I was maybe a little bit hesitant to be able to present and execute before. And that's really where a lot of the value and the benefit of digital techniques are for me. And so I'm excited to show just an example case of a real patient that came into my office that was looking to improve her smile. And we basically just utilized our intraoral scanner and a camera. And we basically designed the case in 2 dimensions. We did a smile design for her. And then I used the information in the smile design to actually do a 3D digital wax up, which we used to do a mock-up in her mouth. And those steps right there, I think for doctors who are just getting into digital, if you can envision these steps and perfect them, you're going to have a much better return on your investments with technology in your office.
Yeah, it's all about setting expectations that the patient agrees with that are achievable, clinically in the mouth. And so you start with a 2D smile design to work out, length and width and overall symmetry of the case. And then you move to a 3D mock-up. And then from there, you'll do the custom temps in the mouth. So walk us through your workflow here and what you're doing, starting with the pre-op photos and the pre-op scans.
Sure. Yes. So this pre-op was taken several years ago, actually, was when this patient first came to us and was thinking about doing some treatment. And when we look at her pre-ops, we actually see that she's got some issues with her occlusion. She has kind of a restricted envelope of function. She's got some wear on her teeth. She's got some rotated teeth. And in this case, we actually took initial intraoral scans when she first came in, and we suggested an orthodontic consult. So she actually ended up going and having orthodontics prior to us doing veneers on her teeth. There's a lot of patients come in and they just ask for veneers, and I think it's up to us to actually look and kind of study the case. And that was the first real benefit of having an intraoral scan, just simply just scanning her teeth and putting them up in the consult and showing her, some of these rotations that she had, and how if we just jumped to doing treatment without doing anything else, that we would maybe have some compromises. Like, look at these bicuspids were rotated kind of 90 degrees. And yeah, we can maybe do veneers here and kind of morph something on the buccals here, but we kind of know that that's not going to give us the best, long-term outcome. And so, step number one is use your intraoral scanner and your camera just to communicate what you're seeing. And once people see, what you're talking about, a lot of people don't want to have orthodontics before getting to the restorative phase because they want kind of instant gratification. But, really just showing her that this was in her best interest, she actually kind of went through with the orthodontics, and she went through Invisalign. It was maybe 18 months or maybe 20 months of treatment. And, the goals of that treatment was to basically unravel some of the rotations that she had, was to, broaden the arch forms to kind of resolve some of this restricted envelope of function that she had. Because you can imagine if we added some length with ceramic here into the existing environment here, that we may be putting that ceramic under a lot of pressure and load, and maybe we're going to have chipping and breakage, and and so these are all the things that you really want to try to see before you've actually done treatment. But after she did that, she came back, and we wanted to envision what kind of treatment would be appropriate for her. What how many units are we doing, the upper teeth and the lower teeth, or only the upper teeth? How many of the upper teeth? And that's really where the camera comes in. So, we started with the Smile Design app that's built into our 3Shape system. And basically we take these two photos, and I'll go back here, and we basically just need a photo of her smiling, and the software basically will kind of segment out where the visualization is going to be. We call that the lip radius. And we get one photo of the patient with their cheeks and lips retracted with their arches apart, and one with them smiling. And the software is basically going to overlap both of those photos together. And if we've taken the photos properly and the patient hasn't shifted their head in between the photos, we should be able to actually overlay both of these photos pretty well. And what that's going to allow us to do is to be able to toggle back and forth when we're doing the two-dimensional smile design. So you can see here when you focus on the upper arch, it looks like there's only one photo there, but it's actually both of the photos, and we've aligned them using 2-point alignment. And, this is, really one of the keys of digital dentistry is data alignment. And, the simplest kind of alignment is let's use 2 points that are present on both of the photos, and let's take those two data sets and overlap them. And, that's basically a lot of digital dentistry in a nutshell, is how do we take two things or more things and align them together? And so now we have an overlay, and we can go through a bunch of different libraries of teeth shapes. And we would try to do this live with the patient. I don't treat this like homework. I basically will do this in front of the patient, in my consult room. And this really was one of those aha moments, because the patients really want to be involved with their treatment. and they love to see themselves up on the monitor, and this is really where you could get inside of their head and kind of get an idea before you've prepped their teeth, before they've committed to treatment, before you've done something that you can't undo. We love to be able to just kind of start to put teeth on the face, and we can add, color and texture. We can start to get an idea from this patient. Do they want to have, really white teeth like this? As some people come in like that, or do they want to have a more natural kind of like A1 or B1? We have such a great opportunity when patients are coming in and asking for these aesthetic treatments to be able to get in their head so that we don't make mistakes, in the final product and the final ceramics and get it in the wrong color or get it in the wrong shape. And so this really allows you to kind of do your homework, and you can really start to, you can look at different measurements like the width to length ratios, and you can start to see, are you going to, lengthen the teeth, or are you going to keep them the same? And then when you hit the toggle, you can see, are we going to have to do anything with the gum lines, or, put this up as an example, because in this case, we actually didn't do any soft tissue surgery. And this is the perfect time in the process to have the conversation as to whether the patient wants to have,
crown lengthening,
the teeth, crown lengthening, or are we going to accept the existing gingival levels? And if that's the case, it's a great thing to do it in the consult, so the patient doesn't come at the end of the case and say, "Hey, why do my teeth look so square?" Right? And so we can have all these conversations kind of before we've done.
Curious here, how long on average? I'm sure there's a big variation, but how long is this appointment with the patient? Because this is a big discussion, right? Length, shade,
schedule about an hour, and basically in that hour, sometimes we're only taking those 2 photos and a trio scan, and then we'll go sit, and I'll take my card, I'll put it into the consult room computer, and we basically just start having this kind of rough draft kind of conversation as to, where the treatment could go. And, once we both start to have an idea on where we want to go with it, we can get it to the point where we have this slider, and we can brand this with our practice logo, and, and the patient starts to get an idea of maybe what this could look like. Now, this really isn't the end of the story. This is just the beginning, because this is basically just a photograph. And, for doctors that aren't yet involved with what happens after this, like, how does this actually become a design? How does this actually become a template for a case? That's really what we want to spend a full day in our 2-day course is devoted to this. It's basically showing you how to take a scan, how to take those 2 photos, how to get this rough draft on the computer screen, and then how to convert it into a digital wax up. Because
yes, so you have a 2-day course coming up, and we'll put a link in the video here and in the posting. But it's a 2-day course where you're going to go hands-on, and day 1 you're going to focus in on smile design, and this first appointment. In this 1-hour appointment, how critical is it that you're setting expectations with the patient? And my guess also is sometimes patients will ask for things that maybe make you uncomfortable, and you kind of have to navigate through what is a realistic outcome of this case that we're doing together.
Absolutely. And when I was first starting out, I was hesitant to do these kinds of cases because I wasn't always confident that I could execute what the patient wanted. And I was frankly, nervous and afraid to prep somebody's teeth and then have them be really unhappy with what I did, and be upset and not be able to undo something. And so I was very cautious, in my earlier years of practice. And these digital techniques essentially got me to the point where I can do this kind of work routinely now, and it's just so gratifying in more than one way. But to be able to actually use these tools in a a protocol and in a predefined, process that it doesn't matter how difficult the case is now. We basically just apply the same tools, and that helps us to learn about the case before we decide to actually treat the patient.
And so before we continue here, my guess is that with this first 1 hour appointment, you're establishing expectations that you and the patient both agree. And then, case acceptance likely is going to go way up, where the patient is going to say yes to the treatment. And then, the patient being thrilled with the outcome. My guess is 99% of the time they're well pleased with the end result because it's exactly what they saw along the way.
Exactly. That's really the key to the digital techniques, is that, yes, this is just a simulation, but we can actually make the final result essentially faithful to this initial diagram or visualization. And typically when I get to this point, there's a patient in the chair and they're excited. So what do we do next? And normally what I'm going to do now is I'll basically ask the patient, I said, how about we see what this is actually going to look like and feel like in your mouth before we actually start your treatment and prep the teeth. And 99% of patients are going to say yes to that. And I should mention that for everything I've done up to this point, we don't charge a fee because it
Really?
costs us
Okay.
time. It costs us 2 pictures and a couple of clicks, and that time in the consult room, which I think is really, really valuable. After
What's
this,
your case acceptance rate when you go through this for free? So there's a little bit of risk of your time. What's your case acceptance rate on average? Obviously, not everyone says yes, but and obviously you kind of pre-qualifying the patient that if they're their willingness to move forward. But in general, what's your acceptance rate?
I would say it's well over 90%. By the time we get to this visit and and we get to an agreed upon smile design, the next phase is going to be the digital wax up and the mock up. And then we basically do the work after that. I can't really say that there's a lot of these that are just kind of sitting up on the shelf somewhere.
Have you established expectations on price, before this meeting, or is it during this meeting? When do you establish those expectations?
The price doesn't really come until after this meeting, because we don't know before this meeting whether we need to do 2 teeth or 4 teeth or 10 teeth.
Or crown lengthening and some other things.
Exactly right. Whether there's ortho involved, whether there may be soft tissue surgery, there could be implants involved. But we really don't even make a treatment plan for the patient until after this visit. And should they choose to move forward, the next phase is they're actually going to pay something to do the digital wax up and the mock-up visit, because then we have to either involve our laboratory, or if I'm successful in convincing doctors after my 2-day course, is that there's a lot of benefit to doctors actually having the lab software and having some fluency, because one of the biggest secrets of digital dentistry is being able to do some of the design yourself and the initial CAD alignment, and basically taking, this really valuable conversation that you've had with the patient and not have to play a game of telephone and try to communicate it to your CAD designer, but maybe you do some of it. You take the photos, you align it to the scan, and you're going to adapt, this change in length and the library of teeth that you chose with the patient, and just to the point of getting a printed mock-up model that you could do a putty and a washover and then fill with your temporary material, and then from there I send it to my laboratory.
So what about the doctor who says, I'm not a technician, I'm not super artistic. How approachable is this smile design software for a doctor?
I think that's a great question, because I think before digital, you really had to be an artist. And, we all found out in our first or second year of dental school, how artistic we all were working with wax and, and trying to set teeth and dentures and, waxing a central incisor. But the great thing about digital is that it democratizes all of that. You don't have to be an artist. Basically, it's so easy to learn. And once you see it, you can't really unsee it. And once you've done a couple of these, I think you would ask yourself why you would ever try to do it a different way. There's so much value to it. Just being able to set the whole thing up for your lab technician to be successful, instead of sending everything to your laboratory and having them figure everything out, there's a high chance that they may not be able to really understand what you wanted out of the case or what you agreed upon with the patient. And that's costly, and I think it stresses the relationships between doctors and laboratory technicians. It stresses the relationship between the patient and the doctors. It's, why not try to control what you can control?
Yeah, it's setting expectations with you and your staff and the patient, and then executing. What about the doctor who wants to train one of his staff members to do this smile design? Is that something you recommend? And could the doctor bring their staff to the 2-day course to learn alongside of them?
I think it's a great idea to bring your team members to a course like this, because you want your team members to be fluent in the language that you're speaking when it comes to these processes. Because when you leave the room, you want the team member to be able to answer the patient's questions. But I would say initially that I wouldn't outsource this to a team member. I would fully support the doctor being involved in this, and this being a critical, piece of knowledge that the doctor should have at the beginning of the case, and their hands and their eyes should be on this part of the case.
Just so that they know what they're doing and what the outcome's going to be, and that they're confident it's all achievable and all of that. I mean, the doctor's time is arguably the most valuable time in the clinic.
Yeah.
But you would say at some level they must be involved in this first appointment,
I think
establishing
so.
these expectations.
I was an analog general dentist, 10 years ago. And within a short period of time, when I invested in learning some of these CAD designs, and, I'm certainly not a lab technician by any stretch, but, I like to think of it in the fact that I know maybe 4 or 5 pathways within the lab software. And one of those pathways, the first pathway, is to learn how to do a digital wax up. And so that's basically one pathway that I know. And, I'm going to repeat the same steps each time. And this, honestly, at this point, I can do these in between patients. They don't take me a lot of time. If I'm going to do, an 8-unit wax up like this case was, I can do that in under an hour. And that has just made me so much more confident in the presentation of the case, the execution of the case. And I think that's really what doctors want. I think that's what they want out of digital. I think digital promises doctors a lot of things. It promises to, have better case acceptance, and you're going to have more predictable results, and you're going to, be able to do cases that you couldn't do before, or make more money than you did before. And how does that actually happen? It's actually this right here. It's actually knowing how to apply all these steps and put them together, and kind of work that into your presentation routines with patients. And it's just amazing after you do this a couple of times, that it becomes fun. And I really want to share, those kind of secrets that I've kind of, learned along the way, because that's really where the promises of digital dentistry are delivered to the doctor.
So you got a 2D smile design, the patients approved it, and now we're going to move to the 3D
Exactly.
mock-up.
Yeah. So, so this is basically, at the end of this consult visit, this patient is really excited. She shared some ideas of what she wanted as far as the scope of the case, and that she liked the shapes of these teeth, and she liked that her teeth were going to be a little bit longer. And so this is by no means the final product, but it really gives me a rough draft to then go do my homework. So now my job at this point is, instead of sending this to my laboratory and having them do a digital wax up, is basically I'm going to come in and I'm going to take care of that wax up for the patient. And so basically in our course, I'm going to show the participants, how to actually get to this point where I have my pre-op trio scan here. And now I'm going to basically use the same library of teeth that we agreed upon with the patient, that the patient liked and that I liked. And I'm going to show them how to do a wax up like this. And then we're going to basically get to the point where we could build and print a model of this. And as I'm building this, I'm going to stay faithful to that two-dimensional smile design that we decided to go with. And one of the neat secrets about this is that if you take the time to do this as a doctor, you essentially get to do a dress rehearsal of your case before you actually sit down with the burr. And as I'm building this, I'm going back and forth to the two-dimensional smile design photo. And as I'm going here, I can figure out, hey, can I be additive in the case? Do I have to be reductive? And if I'm going to be additive, how much am I going to have to prep the teeth? How much can I preserve? And being able to do this, I can take cross sections at any given time here. And this is really valuable for doctors to do. And I think that this is the opportunity for doctors to do this, instead of letting the technician do this and get to see all these things and learn about these things, is that the doctors can learn about it, right? And, I can come in here and take this cross-section and I can see, how much am I planning to add to the incisal edge? Okay, I'm going to add about 1 millimeter. Okay, that's exactly what I added to in the smile design. And when I'm preparing the teeth now, I know, where I can be more conservative, or, what the guidance pattern is going to be. You basically learn about your case. And shouldn't you learn about your case before you treat your patient?
Totally.
Isn't that a useful thing to do? I mean, wouldn't most doctors do that if they had the ability to do so? And why don't they so far? It's that, well, we weren't taught this in school. And a lot of these tools are at the laboratory, and they're in the hands of our technicians and our designers. But if we can just get to this point, and then I can have the patient back, and I'm going to basically print a model of this design. I'm going to make...
Can I ask a quick question here?
Yeah.
How often are you doing any virtual reduction in the mock-up? Are you typically just, doing the mock-up over the existing teeth without any preparation?
Yeah, you know what? I think that's a good question. We try, I try in every case to be additive if possible, even if it's only 0.5 millimeter. But there are cases that you can do it additively like this. And I understand there's going to be cases where you can't do it and you need to reduce, and that does make a mock-up a little bit more difficult. It's not impossible. But I would say the majority of restorative cases are going to be additive in some way, even if you're only adding 0.5 millimeter. And, and that still makes it a valuable thing to do. And so if I can take that design and I can transfer it to the patient's mouth, and I can say, here's our 50-50 shot. It's just like our slider, and this is actually, I actually decided this is more for my benefit than the patient's benefit, because the patient...
Why do you say that?
Patients, I've found, will almost buy treatment based on that photograph, because they're going to trust, they're going to trust that you're showing them this photograph and you can do it. And what they don't know is that you don't really know if you can do that or not, because you can make a photograph look whichever way that you want. But what you don't know is what that design on the two-dimensional screen is going to look like and feel like. You don't know what the phonetics are going to be. You don't know what the function is going to be. And you want to actually, as a doctor, know that this design, this beautiful design that you got excited with the patient, is actually going to work in 3 dimensions in their mouth. And that's what this mock-up is for. So the
Mm.
mock-up is more for the doctor than the patient, in my opinion. Because once I do this mock-up and I see it, and I see my design from the computer screen transferred, into reality, into this patient's mouth, then I get an idea, and I'm seeing them speak and smile, and I can have them kind of grind their teeth around. And that's my final check on my own work. And that's my final
Mm.
kind of checklist to say, hey, this is actually going to work, or if something is horribly wrong, I'm going to find out right now. And we can hit timeout, and then we can go back one step and we can make changes.
So yeah, a great point. This is something where you might catch something that's, clinically challenging that the patient is unaware of.
Exactly.
But then this is the point where you then say, well, you got a little rotation here. We're going to have to take care of that like this. Or maybe you do need gum surgery after all. We were going to try to avoid it, but what do you think? Right? Like those
100%.
types of conversations.
And those kinds of conversations they are so invaluable, because you don't want to figure those things out on the day of prep. Once you prep the teeth, and you're in the case and you cannot reverse what you've just done. That's a nightmare.
Those are the surprises that are going to cost time and money. And then who pays for that? Are you going to pass that on to the patient when they were like, I didn't think we agreed to that? And you're like, well, you kind of need it now. So
Exactly.
might as well get all that sorted out in this appointment.
Yeah.
How long do you have them wear this mock-up?
So in many cases, it's really just a 1 hour visit where I'm going to basically put this on. They'll get up and we'll take these photographs. They'll go over by the window. Maybe they have a significant other with them, but you can easily send them home with this I've done it for 24 hours, and they come back because it's not actually bonded on. You can peel it off.
What type of material are you using for this
This
mock-up?
is a bisacryl by, I believe, a company called Exacta.
Okay.
So it's basically like a non-brand, like Lexitamp, like that. They all work pretty well. I just have happened to be using this one for the last 15 years. And you can easily send the patient home, and they can go and they can show their parents, they could show their girlfriend or their boyfriend, because it's a big investment, and patients love being able to be able to be put into the driver's seat with these types of decisions prior to having the treatment started.
So my guess is when that patient leaves and they show their family and friends, that's the moment where treatment is like locked in for them. They like fall in love. They're committed. Now they're coming back saying, when do we get started?
That's typically what happens. I have to say that in my experience in recent years, once we get to this point, the next visit, we are scheduling our prep visit, and then, from this point on, really any dentist can take over from here, because now you're going to prep the teeth, based on the way that we did this mock-up. On the day of prep, I do this mock-up again, and I cut my depth cuts, through the outer edge of the mock-up, so that I can be more conservative where we plan to be additive and whatnot. And then it's retraction, it's impressions, whether it's a digital impression or an analog impression. And then, then all of this goes to the laboratory. And now your laboratory technician is really empowered, because they don't have to make these critical decisions about the shapes and the sizes and the widths and the lengths and the occlusion.
Oh, I'm sure your lab loves it because everything's worked out.
It's worked out, and now they can do what they're trained to do, which is to make beautiful restorations, and I want to empower them to get it on the first try, so that when we go to deliver the case, final case basically looks like the mock-up, and the mock-up basically looks like the smile design. And when you put this in, there's no surprises. The patient basically says, yeah, it feels like my temporaries, which felt like the mock-up, which looked like the smile design. And it just makes this case is so much less stressful.
Oh, for sure.
Yeah.
Less on you, less on the lab, less on the patient. Everyone's happy. You started with the 2D design that they approved, and then they wear home the 3D mock-up. How often do they come back saying, I want them longer, or I want them wider? Is it
not often? Because
low
I
percentage?
think, we basically work out the majority of that in that smile design visit. And we generally get the metrics just about where we need to be. What I didn't say here is that after we prep the teeth and we use the same putty matrix that we use to do the mock-up to make the provisionals, we actually still don't have the laboratory make the case. So we usually will wait. The patient will come back a week or two with the provisionals, and that's where we basically make any minor changes, and where we may make some small changes to occlusion or to the incisal edges. Then we scan that. We scan the approved temps that have been in the mouth for at least a week. Mm-hmm. And basically the laboratory is going to copy that,
So this is a brilliant step. So you do the preparation.
Yeah.
You send the patient home with the temps that they wear for a week or two.
Yeah.
And then you're going to take the final scan. So if they did want something tweaked, you'll capture that. Take the final scan.
Day of prep, I've taken all of my final impression scans. The only thing that I don't have is the approved temporaries. And so a week later, we tell the lab, we send the lab all of our final impression scans, the pre-ops and the mock-up scans, but we say, don't actually start this case yet. We're going to see the patient back a week later and just be sure that we're not making any tweaks or any changes, because we don't want them to copy the temporaries if in a week they came back and said, hey, they feel a little long, or hey, I'm lisping a little bit, or my bite isn't right. We want to actually wait a week, make any changes that we need to. And then at that point, I just take a very simple scan only with my intraoral scanner. And now the laboratory can take that and they can align my preparation scan to the approved temporaries. And now there's literally no game of telephone. And so with each step, it basically gets dialed in a little bit closer and a little bit closer, so that the final should really be a stress-free kind of visit where everybody knows what they're getting.
So how many patient appointments was this case?
So the first visit was a smile design. So that was a 1-hour visit. About, I would say, less than a week later, they came in for the mock-up. So let's call that visit 2. Visit 3 would be the prep day, right? So that's our long visit where I'm prepping the teeth and doing retraction, making the temporaries, scanning the teeth. Then they come back a couple of days later, let's say a week later, for a quick post-op. So this is a very quick visit where we get some photos, we make any adjustments of the temps, we scan the temps, and then the following visit is the delivery. So we've made it. I'm not going to say that this is a 2-visit case, because it's not.
It's not,
because it takes these specific visits, and they don't take a lot of time. But what it does is when you put them together, is you get a predictable process. So maybe this was 4 visits, or maybe it was 5 visits to the office. But the real big visit was the prep visit. That's where, we schedule a bunch of hours. All of the other visits are either side books or they're, consult kind of appointments, So, I'm not, I don't think I need to sell this as a 1 visit kind of thing or a 2 visit thing. It doesn't matter.
So
for appointments, right, it's worth it.
Yeah. What percentage of the time does the patient love their final crowns when you follow this process?
I mean, I'm gonna say 100%. I'm gonna knock on wood, because thank God, we've never had to go back and start over. And that's really the beauty of the process, is that when you reach your final endpoint. It's what everybody expected and wanted.
And how much word of mouth do you get from your patients to new patients?
Yeah, I think that this is just like any other thing in your practice. Once you really can, offer this as a service up on your shelf of things that you can provide, that, once you do one, then you get to do another one. It was interesting. We did this case maybe it's almost it'll be 2 years this year. We are going to actually do a very similar case on this patient's husband because he was so happy with what we did for his wife. And he basically came and said, I want what you did for my wife, and we're actually just at the point, we just actually took we did our smile design for him, and he's coming in, I think, next week to have his mock-up done.
Wow.
And so it's just, it's a valuable process. And I think once you learn it and the doctors own this part of it, this really is one of the big secrets to digital dentistry. It's not just I bought a scanner, or it's not just that I have this smile design app. It's you can put it together and spend a little bit of your time on the front end, you
Mm,
really get to benefit from all of the things that come after.
I love it. Absolutely love it. So this is day one
This
in
is
your
day one.
upcoming
Yep.
hands-on course. So doctors will be able to scan a model, do a 2D design, do the 3D design, all the way to what they need for doing the mock-up, right?
Exactly. Exactly. And if you have those steps, then you're going to be able to take those steps and build upon them. And in day two, we basically will do similar kinds of steps, but be able to actually scan a denture, to do a denture tooth setup, to be able to print out a prototype denture. And, that is how you sort of build upon your skills to become a more fluent digital dentist.